Well, a warm welcome to this talk, and regular viewers to the channel will be no stranger to Professor Norman Fenton. Norman, welcome. Thank you for coming back.
Thanks for having me on again.
Great to see you. Mathematician, and still at the moment, I believe, Professor of Risk Information Management. I know you're about to retire. yeah. So, just a basic question, really, to begin with, Norman. What is risk information management?
Well, it's actually a term that we had to make up as a name for the research group, which until a few weeks ago I ran at Queen Mary. I mean, originally the group was named Risk Assessment and Decision Analysis, which accurately described my own interest, but we later combined with a different group whose focus was on information retrieval, hence the renaming. It's really just a rebranding. But what we mostly had in common was that we used probability, especially a type of probability called Bayesian probability, to improve decision making, especially in critical applications like health, finance and law.
Give me a clue on Bayesian probability, Norman. I'm a bit rusty, I'm afraid.
So Bayesian probability is all about how to properly update beliefs in uncertain events, things that we don't know for sure whether they did happen, are happening or are happening in the future. So it's about how we update our belief in those, given new evidence relevant to those events. So just as an example, maybe relevant to the discussion today, if 1 in 1,000 people without COVID symptoms are known to carry the virus, then we can assume as a starting probability that there's a 1 in 1,000 chance that I've got the virus if I have no symptoms. So that's our so-called prior probability. But suppose I take a PCR test and it comes back positive. How do I know what the revised so-called posterior probability is given that piece of evidence? Well, it's Bayes that tells us how to revise that probability, taking account of what we know, for example, about the accuracy of the test.
So it's probability basically that's constantly updated every time a new piece of information.
Yeah, every time new information
comes along.
Comes along.
Yeah, and I'm not going to ask you to do this, but you can prove all this mathematically, presumably.
Yes, yeah.
Yeah.
I mean, it's accepted that Bayes is the correct rational way to revise probabilities in the light of new evidence.
Yeah, for sure. Now thinking about risk and indeed benefit, there's been a lot of talk lately about absolute risk and relative risk. I mean, basically, what is the difference between the absolute risk and the relative risk?
Okay, probably best to explain this using a sort of a simple example. If you can, maybe if you can share that second slide.
Yeah, I think we can do that. I think is that the slide you wanted there, Norman?
Yeah. So absolute and relative risk. These are different ways to measure the effectiveness of a treatment, or which, for example, could be a vaccine, and also different ways of also measuring, adverse reactions to a treatment or a vaccine. So let's take the example of measuring the effectiveness of a vaccine. If you can just click through. Yeah, so suppose you've got a new vaccine and it's trialled for a known virus which affects 8% of the population. So 8 out of every 100 people, before the vaccine comes along, are going to be infected. Well, suppose this trial takes 100 unvaccinated people and 100 vaccinated people. Then obviously you would expect to find about 8 cases in the unvaccinated, because that's what we know from the population previously. Well, let's suppose that amongst the 100 vaccinated, you find only 2 cases. Then what we can say is that the absolute risk of getting the virus in an unvaccinated person we know is 8%. That was already there. But now the absolute risk of the virus in a vaccinated person is only 2%. So if you can just click through again. So formally, the absolute risk reduction in getting the vaccine is just the difference between those two risks. So it's the absolute risk of infection without the vaccine minus the absolute risk of infection with the vaccine. So it's just 8 minus 2, and that gives you your 6%. That is the absolute risk reduction measure. And you can also, again, depending on how you're viewing this, you can also think of it of the absolute risk increase of not getting the vaccine, right? What's the increased risk if we don't get the vaccine? Well, in that case, it's going from 2 to 8. So again, it's a 6%. So the absolute risk reduction in getting the vaccine is 6%, and that's the same as the absolute risk increase in not getting the vaccine, right? But the relative risk is a very different measure. So informally, the risk of infection amongst the vaccinated is 25% that of the risk of infection among the unvaccinated, because 2 out of 8, that's 25%. So that's how we get this 25% relative risk of infection there. So relatively, that's a 75% risk reduction, right? Because we're taking away the 25%, and that formally, that's how we define the relative risk reduction measure. So the relative risk reduction of getting the vaccine is just 1 minus the proportion who get the virus divided by the proportion so it's 1 minus the proportion of vaccinated who get the virus, which was the 2%, divided by the proportion of unvaccinated who get the virus, that's 8%. So it's 1 minus 2 over 8, that gives you 1 minus a quarter, which is 0.75, which is 75%. So that's how they formally define the relative risk reduction. And actually, just click through, that's also formally how efficacy of a vaccine is defined. So formally, they would say the efficacy is 75%. So if you only hear efficacy, they are always talking about the relative risk reduction. Okay? Now, we can also consider the relative risk increase of not getting the vaccine. Now, since the rate amongst the unvaccinated is 4 times that of the vaccinated, because again, it was 8 against 2, so that's 4 times, that means not getting the vaccine would increase the risk of the infection by 300%. And formally, it's that, again, that's just the formula of the percentage of unvaccinated who get the virus, now divided by the percentage of vaccinated who get the virus, minus 1 as a percentage, and that gets you to 8 over 2 minus 1, which is 3, which is 300%. And that's, again, that's a different way of, whereas the absolute risk increase and the absolute risk reduction are the same, they're not the same when it comes to relative risk increase and reduction. So we've now got, the interesting thing, we've now got 4 different measures of risk, but there's another one which in many cases is more intuitive, and that's the number needed to treat. So the number needed to treat, we're asking how many people do we need to treat, in this case with these vaccine, in order to have one person being stopped from getting infected. And that's defined as simply, do you want to click through this next one? Yeah, and that's simply defined as 100 divided by the absolute risk reduction, which is 100 over 6, which is 16.7. So we need to treat, 16 or 17 people in order to get one person to avoid one infection, using this this particular vaccine. So what you can see there is that they're all different. All these measures are different. So you need to know what, if you're given if you're told about risk reduction, you need to know which, or risk increase, you need to know which ones are being spoken about here. They're very different.
It sounds a bit like the level of risk can be presented in a way that gives a particular impression of greater or lesser risk than benefit, depending on the point someone's trying to get across here.
Yeah, if you just think about the example, the numbers in that example, just imagine if all you are told is that the vaccine reduces the risk by X%, you're given a number. Well, you really need to know if that X is the absolute or the relative risk reduction. If you're told, for example, because you could be told that there's a 75% reduction, well, that's the relative risk reduction. Now, that sounds a lot more impressive than the 6%, which is the absolute risk reduction. And even more so, if you're told there's a 300% increase of the virus if unvaccinated, that was the relative risk increase, that sounds a lot more scary than a 6% absolute risk increase of not taking the virus. So, you've got these differences. They're all different. You need to know exactly which one they're talking about. Otherwise, you might have a massively, overestimated perception of what the risk is, or underestimated, if, depending on your perspective. Now, there's also another problem, is that there's also a major issue concerning whether the risk measure you're using apply to the whole population or only to people, for example, who have a particular condition. So, for example, let's suppose you've got a drug that's tested on 200 people with a particular condition. So, for example, suppose a drug is tested on 200 people who've got a particular type of cancer. Now, 100 get the drug and 100 get the placebo. Then, suppose we know that using the same figures as before, suppose that 2 out of those getting the drug die of cancer within 12 months, compared with 8 who die of cancer of that particular cancer within 12 months who get the placebo. Then, because I've used the same figures that I used in that previous example, we know that the absolute risk reduction of dying for those getting the drug is 6%, but the relative risk reduction is 75%, while the relative risk increase of not getting the drug is a whopping 300%. Now that sounds really impressive. Again, if you were told that the relative risk, the relative risk reduction of taking this drug is 75%, that you won't die within 12 months, and that the relative risk increase of not taking the drug is 300%, not dying within 12 months. You think this is really, this is a drug, this is really important. And so let's suppose that it's a rare cancer, but let's suppose it's a rare cancer affecting only 1 in 100 people who have a particular risk factor associated with that cancer. Then you might decide, because you've got these really impressive results, you think, well, let's give this drug to everybody who's got that risk factor, right? But if it's affecting, if only 1 in 100 people with that risk factor get that cancer, then you can imagine 10,000 people with the risk factor who are given the drug. We know that only 100 are actually going to get the cancer. And of that 100, we know that 2 will die within 12 months if they get the drug, and 6 will die within 12 months if they don't get the drug. So basically, what we've got then is that for every 10,000 people with the risk factor, so for people given the drug, the absolute risk of dying of the cancer within 12 months is 8 in 10,000, because we started with 10,000, but only 8 are going to die of cancer if they're not given the drug, whereas those given the drug, 2 of them are going to die, 2 in 10,000. So we've still got the same relative risk reduction, 75%, but the absolute risk reduction is just 6 in 10,000, which is 0.06%, which isn't a lot at all. And if it turns out that, let's say, 1% of people suffer a serious side effect, then in 10,000 people given the drug, 100 will suffer a serious side effect compared to just 6 who'll benefit from the drug. So you getting these numbers, getting the measures, understanding what the correct measures and the correct population of people who are given the treatment is really, really important.
So that's talking about the benefits of treatment, but could papers in medical journals also give the impression that an adverse reaction was less common than it might actually be? Yeah,
I mean, as the example, given the example I just explained, if you wanted to push a particular novel medical intervention that has a very low absolute risk reduction, but has a reasonably high, relative risk reduction, then if it also has, for example, as yet unknown adverse reactions, then you'd certainly want to emphasize risk reduction using the relative risk increase rather than the absolute risk. Sorry, the relative risk reduction rather than the absolute risk reduction. That would be the way to do it.
So an unethical medical author in a paper could, in terms of efficacy, be talking about relative risk reduction. and in terms of adverse events could be talking about absolute risk reduction and give complete, I mean, we're not saying anyone's done this, of course, but that would give completely the wrong impression if that were to happen.
I can tell you that it has been known for authors to state the benefits of the proposed medical intervention using the relative risk reduction, while, if they're forced to, giving the risk of adverse reactions using the absolute risk reduction. In other words, the benefits are shown in the most positive light and the risks are shown in the least negative light. And that's going to increase chances that a study is going to be accepted as significant.
Oh, that's just incredible, isn't it? I mean, it means that a particular treatment would be taken by most doctors who would probably just read the introduction and conclusion to that article as being efficacious and safe. Yeah. Or maybe we could even use the term safe and effective, when in fact it's not safe and effective as it would indicate.
If it was presented in that way, that is the conclusion that most people would come to if they don't dig in deep and look at the differences between these different risk measures.
Yeah. So is relative risk reduction always going to be higher than absolute risk reduction?
In fact, mathematically, you can prove that the relative risk reduction must always be at least as high as the absolute risk reduction, and it can only be equal if you start with 100% of the people being infected, in the case of vaccination, 100% of the people being infected before the vaccination. Because in that case, suppose the vax reduces the infection rate from 100% down to 30%, then the absolute risk reduction is 70%, and the relative risk reduction is also 70% in that case, because it's 1 minus 3/10 as a percentage of 70%. But the absolute risk reduction can never be less than the relative risk reduction, because even if you think about it, if you start with 90% and the vax reduce it to 20%, then we've still got the absolute risk reduction of 70%. But in that case, the relative risk ratio is now 1 minus 2/9 times 100, which is 22.2%, which is a bit higher than the absolute risk reduction. So it's always at least as high. And normally many, many times higher than the absolute risk reduction.
Or orders of magnitude higher sometimes.
Yeah.
Why can the relative risk reduction vary between populations and vary over time?
Well, during during trials for a new treatment, the subjects, for a start, won't necessarily be typical of the whole population to be targeted for that treatment. So for people with different specific conditions, symptoms, risk factors, etc., even the relative risk ratio will therefore be different once it's rolled out to different, to slightly different populations. So, for example, people with certain lifestyles may be more or less likely to be infected with a virus, irrespective of whether they take the vaccine. And similarly, they may be more or less likely to suffer adverse reactions if they have certain risk factors. Hence, in those cases, the relative risk ratio will vary. However, even if you've got a perfectly homogeneous population taking a new drug or vaccine, such as a vaccine that against a particular virus that, let's say, evolves over time, then the relative risk ratio will certainly change as the virus itself evolves.
Yeah. And am I right in thinking that the absolute risk reduction, let's say of a vaccine, if there was a relatively low amount of the virus in the population, the absolute risk reduction would be less than if there was more virus circulating in the population at a period of time? Yeah,
because that's kind of like analogous to the example I gave with the fairly rare cancer. It's where, because you've got to take account of the in that case the trial that you used the data on didn't take account of the fact that the incidence rate in the population was actually very low. So if the incidence rate in the population decreases over time, then again the absolute risk is also going to be much lower again.
I think that's what I found difficult when I was trying to assimilate this, that the absolute risk reduction is not an intrinsic property of a drug or a vaccine. It is the way that a drug
No.
or a vaccine interacts with a particular population at a particular time under a particular set of circumstances.
Exactly. As the population infection rate changes, if the population infection rate goes down, the absolute risk reduction will also go down, and if the infection rate goes up, then the absolute risk reduction will also go up.
Now, I'm a bit confused. The way that risk is reported, the benefit of an intervention and the risk of adverse reactions is reported in medical journals. It surprises me that I would have expected the editors of large international prestigious journals to be fully aware of this material, and yet particular impressions can get through to being published. It really makes me wonder what some of the editors are there for, to be quite honest. But without talking about any specifics, how could reporting in medical journals of relative risk, numbers needed to treat, absolute risk, how could that be improved?
Well, apart from making clear the very specific features of the population targeted for medical intervention, and also ensuring that any trial or observational data is based on a suitably representative sample of that, what they should be doing is reporting both the relative, well, I think the absolute risk reduction is probably the most important, but you should be reporting both. You should be reporting the absolute risk reduction and the relative risk reduction for both the benefits and the adverse reactions. So that's four different measures, right? And probably even better, you should definitely also be reporting the number needed to treat, because, as I said before, that's something that lay people can really understand.
It's much simpler,
quite
isn't
easily,
it?
because for example, if you know that the number needed to treat is 100, then we know that for every 100 people given the treatment, one will benefit from it. But if you also know that 1 in 100 given the treatment is going to suffer a serious adverse reaction, then we can conclude that for every 5 people who benefit from the treatment, only 1 will suffer a serious adverse reaction. And in that case, having those two equivalent, numbers to treat and numbers to adverse reaction, in that particular example, that would tell you that, that the benefits outweigh the risk. But of course, if the number of adverse reactions, is higher than the number needed to treat there, then it flips the other way.
And of course, as you've rightly said, we could be in a situation where a drug looks favourable, but in actual fact, the absolute risk of adverse reactions is greater than any efficacy that could be gained from them.
Exactly, and that's why you have to consider both.
Yeah, from the preparation. So any editors of medical journals watching, what I'd personally like to see in future is absolute risk reduction, relative risk reduction, and numbers needed to treat reported on the efficacy of all new interventions, whatever that intervention is, whether it's a vaccine, whether it's a drug, whether it's whatever, whether it's a physical treatment, anything. And we'd also like to see, in terms of adverse events, we'd like to see the relative risk and the absolute risk given for adverse events. Is that too much to ask editors of medical journals? Surely not.
Absolutely not. I mean, absolutely not.
In fact, the fact that we have to ask that question is ridiculous.
They should have all the data. I mean, the one problem is, of course, for new treatments, they won't have, or in many cases, won't have studied the treatment long enough to get good data on the adverse reactions. And of course, that is a big problem. And so a lot of the times they're reporting the relative risk reduction, i.e. where they're simply looking at how well the drug does in treating or stopping whatever it is it's supposed to do, and not looking at all at the adverse reactions in any quantitative way.
Which brings us on to a completely different matter that we're not going to talk about today, which is post-marketing surveillance, which there's question marks over, but I'm not going to get into that at the moment. Now, I believe you are vaguely familiar with this paper here, Norman. This paper is about
Yes.
This is efficacy and effectiveness of COVID-19 vaccines, absolute versus relative risk reduction. And this is published in the journal Expert Review of Vaccines, and it is peer-reviewed. And the numbers here are quite staggering. So, for example, for the Pfizer vaccine, this is based on the original phase 3 trial data,
Yep.
the data from which governments all around the world made the decision to give millions of us this vaccine, the relative risk reduction was 95%. But the absolute risk reduction at the time of the trial was 0.84%. I mean, the emotional impact of those, even as a non-mathematician, of the difference between those two numbers is just, I just find that incredible. And the numbers needed to treat was 119. For the Moderna, the relative risk reduction 94.1%, the absolute risk reduction 1.24%. Numbers needed to treat 81. Now, to be fair, in the 5 or 6 months after that, the absolute risk reduction from the Pfizer vaccine did go up to, I think it was 3.7%. But it's still one heck of a difference from 95%. I mean, it's a bit of a subjective question, really, but if these numbers had been known about and presented in the way that we have just requested medical journals to present their results in future, do you think that would have made a difference to political decision making?
Yes, I think it does.
I
really
do.
Don't know that there's a big difference between the relative risk and the absolute risk.
Yeah.
And and therefore, if they're told 95% as opposed to 0.8, less than 1%, that's the difference between wow and so what.
It really is. I mean,
I'm happy to show exactly how. If you want to know exactly how those figures were computed from using the trial data, I prepared a slide on that as well.
Is that on this on this?
To go through that.
Is it on this? Is this one we're
It's the
looking
next
at?
slide. Yeah, just click.
Yeah.
We'll
Look at that.
I've got
We'll look at that, please. Yeah, but before we do that, even the Oxford AstraZeneca vaccine, the relative risk reduction 72.8, the absolute risk reduction 1.11. I mean, and the number needed to treat 90. These numbers have huge imports. So yeah, let's look at that.
The interesting thing about come back to the AstraZeneca in a minute because I've got some insights on it.
Let's go on and
Pfizer.
let's see if we can see that.
So look at the Pfizer trials.
Yeah, that's the one we're looking at. So this should be the next one. Yeah.
Yeah, so it's all here. So basically, those figures that you've given that are in that paper are based on the Pfizer randomized controlled trial, and that had 43,000 individuals who were aged at least 16. And again, they were equally, so about 21,500 were given the vaccine and an equal number given the placebo. And of those who got 2 doses without any evidence of having a prior infection, and they looked at the results, they observed the results 7 days after the second dose. What the results were and what everything is based on is these 2 figures, that there were 8 cases of COVID out of 18,198 in the vaccinated group and 162 cases of COVID in 18,325 in the placebo group. So the entire thing, all of this, all of the emergency use authorization was granted on the basis of just 170 cases. That's something to consider for a start. But where do the numbers come? Well, that means that the absolute risk of COVID in the vaccinated is just that 8 over that 18,000 odd, which is 0.0044%, and the absolute risk of COVID in the unvaccinated is 162 divided by that 18,000 or whatever, and that gives you the 0.884%. So the absolute risk reduction is simply the difference between those, which is where you get that 0.84% figure. So that's how that's arrived at. Okay? Whereas using the formulas I presented earlier for the relative risk reduction, where you're looking at the percentage of vaccinated who got COVID over the percentage of unvaccinated who got COVID, and that's where you've got the 8 divided by 162, that's what gives you, and then 1 minus that, that's what gives you the 95% efficacy, i.e. the 95% relative risk reduction. So you've got that there. You can also look at the relative risk increase, which incidentally, they could have even been more. They could have even more, let's say, deceitful, they could have given the relative risk increase, which is actually almost 2,000%. But it still doesn't change the fact that the absolute risk increase is less than 1%. And of course, the number needed to treat is just 100 divided by that absolute risk reduction, which was a 0.84%. And that's where you get the number 119. And so that's how the...
this is not complicated mathematics, Norman, because I'll tell you how I know that, because I can follow that. And if I can follow it, it's not complicated mathematics. That really is...
it really isn't.
Yeah, I'm sure quite a few people are reeling from that. That's what's on the next one? Do we want to talk about this one?
Yeah, well, this is in relation to, because you mentioned about that paper was claiming that the later studies were showing that the absolute risk was increasing quite a lot. It was going up to 3.7%, as high as that, for example, for Pfizer. But there's a problem, because there are two issues that massively compromise efficacy measures, especially in the observational studies, which most of those later numbers were based on. Yeah. Right? Now, the first of these, which again is something which is especially pertinent to observational studies, it's actually also pertinent to randomized control trial, because there was an issue about this with the Pfizer trial. It's about people who actually get COVID or get whatever the virus is, whatever the vaccine is, people who actually get the disease or the virus shortly after being vaccinated. Right? Now, on the one hand, people will argue, well, if you want to measure effectiveness, you've got to allow the vaccine time to become effective. Right? Hence, it's normal to consider people who get the vaccine but become infected shortly afterwards, and they normally say up to 14 days, to consider those as unvaccinated, right? Because the vaccine hasn't had a chance. Well, that's all very well and good, but you have to be very careful in your numbers of how you treat the numbers in that category. Because if for example, you've got an explosion of people getting the virus shortly after vaccination compared with those who get the placebo, then that's actually telling you something very important about the vaccine, which needs to be, you shouldn't be throwing that out and treating those people as unvaccinated, right? But it's even worse, because if you go on to I've got a little sort of little graphic, if you go on, which sort of explains the impact of doing this. What often happens, what happens of treating these people who are infected shortly after vaccination as unvaccinated. Let's start with a generic example. Imagine you've got a non-fatal disease, which in every 2-week period infects 10% of the people. Okay, click through. Next click. And suppose that people receive a vaccine which is supposed to protect against the disease 2 weeks after it's taken, but which is actually a placebo. So we're now going to observe some people get the vaccine and some who don't. So go on to the next one. So we've got 100, let's suppose we've got 100 people in the vaccine group and 100 people in the no vaccine group. So click on. So the people in the vaccine group and in the no vaccine group, there's going to be 10% infected in weeks 0 to 2, irrespective of which group they are, because the vaccine is just a placebo. It has no effect. Okay? So we're going to move. So in weeks 0 to 2, we've got, if you click, you get the 10 of the people in the vaccine group, they become infected. And in the no vaccine group, 10 of those come down, they're infected. Now, in weeks 2 to 4, the next 2 weeks, 10% of those previously uninfected, which in each case is 9 out of the 90, also become infected. So we're going to get another 9 in the vaccine group become infected and another 9 in the no vaccine group become infected. So what we've got overall is that in each group, 19 out of 100 get infected over the 4-week period. And if we want to apply that formula for the relative risk reduction, which is next, of course it's 0, because it's just, if you just click the formula, it's just 1 minus the proportion vaccinated infected over the proportion unvaccinated infected, and it's the same, so it's 0%. But suppose, and that's right, because a placebo should have zero efficacy. But let's suppose that those infected in the first 2 weeks after vaccination are classified as unvaccinated. Let's see what happens now. Click on. Yeah, so now those 10 who were in the vaccine group move over to the no vaccine group. So what we've now got, we're left with 9 out of 9 who are classified as vaccinated. We've got now 9 out of 90 are infected. That's still 10%. But we're now classifying 110 as unvaccinated, of whom 29 are infected, which is 26.4%. And if you apply that efficacy measure, that gives you're already up to 62% efficacy for this placebo, simply because of this mathematical trick of switching, of classifying those who are infected in the first week in the vaccine group into the no vaccine group. They're classified as unvaccinated. And it gets even worse, because actually...
Let me make sure I've got this so far, Norman. You've just demonstrated that a placebo is efficacious.
And you can demonstrate that it's high. You can get easily to 95% accuracy, relative risk reduction efficacy, because if you get now, as is the case, with mass vaccination, we were observing much higher proportions of vaccinated than unvaccinated. So go on to the next slide. Just imagine now you've got 500 in the vaccine group and only 100 in the no vaccine group. And we do the same argument again. We look at what happens in the first 2 weeks. 50 out of the 500 are going to be infected in the vaccine group, and we're still going to have 10 in the no vaccine group infected. And then in weeks 0 to 2, again, you're going to get 10% of the previously uninfected, which is 45 out of 450 in the vaccine group. So you're going to get another 45 coming down there. You click on. Yeah, they're going to move down. And again, with a no vaccine group, you're going to get your 9. Now, what happens when we move those infected in the first 2 weeks who were vaccinated to the no, to classify them as unvaccinated? They get shifted over there. And what are we left with now? We've got 45, we've got 50, so we've now got 45 out of 450 who are considered vaccinated get infected. That's still your 10%. But of those who are classified as unvaccinated, we've now got how many? We've got, if you go on to click on, 69, because we've got 60 plus the 9, that's 69 out of 150 classified as unvaccinated, which is 46%, and you're already up to 78% efficacy. And you can easily, in observational studies, and we know this happens, that can push up to easily over 90%, since we know in practice that those people who've been vaccinated are less likely to have to get tested than the unvaccinated. And so fewer of those who are vaccinated who really have the virus are actually recorded as having the virus. And if, for example, only 1 in 3 of those who get who have the virus are tested compared to those who haven't been vaccinated, then you push this up to well over 90%. And it's just a statistical illusion. It's just a trick.
So we've now demonstrated the placebo has
and
a
the
90%
other one,
efficacy.
yeah.
You heard it here.
Get a placebo. You can easily get.
You heard it here first. Placebo has 90% efficacy. I don't think
You can even get a dangerous placebo getting up to 90%, i.e. one which actually causes, if it causes adverse reactions in the first 2 weeks, because you're classifying those, you're pushing those into the unvaccinated group, you can actually get a dangerous placebo being classified as safe and effective.
I mean, to what extent, again, is this reflected, do you think, in the way that policy has worked out over the last few years?
I mean, those, of course, I'm using theoretical numbers.
Oh, this is entirely theoretical.
We know, this is entirely theoretical, but we know in many of these, even in the Pfizer trial itself, how they dealt with those who did get infections shortly after vaccination. There's a lot been written about this, and the the fundamental flaws, multiple, protocol violations in that trial. I mean, including the fact that, although they were looking at these so-called confirmed cases, which there are only 170, but the study also reports there was a much larger number of suspected but unconfirmed cases. And they were actually quite relatively evenly spread between the vaccine group and the placebo group. And so it also suggests that a disproportionately small number of the vaccinated participants with symptoms received PCR tests compared to placebo participants with symptoms.
Well, that's simple.
And they
simple selection bias, isn't it?
They excluded participants who developed COVID before the second dose. So again, they had this problem. I mean, this was a problem. In fact, we know that 143 patients were withdrawn because they had COVID before the second dose, and a lot of those were actually at one site, which was another part of the problem. Okay. So
we know
in a lot. Sorry.
So go ahead, Norman.
No, we know in a lot of the observational studies this issue of not classifying people who get COVID, within that first 2 weeks vaccination, that absolutely compromises the results in many of these cases, and that's why I don't really believe those 3% absolute risk reduction. But there's the second reason. Which I want to come on, which I also prepared a little animation for, and that's all to do with having to get a good estimate of the total number of people in the population who actually got the vaccine, i.e. how many were unvaccinated, what proportion were unvaccinated, and what proportion were vaccinated. And this is massive. The difference, so if you go, I think it should be the next sort of animation here. If you click through, that was what we just said about that. So we might not know, the true proportion, right? So imagine we've got a population of 10,000 people, and we know that, let's say 100, actually in this case I'm going to talk about dying from a treatment. I'm not going to talk about a vaccine, just any treatment. Just suppose 100 people die of this disease, right? So we've got the 100 people there. Okay, so click through. So we know, if you click through, so 100 die of this virus. So 100 out of 10,000 die of the virus, which is a mortality rate of 100 per 10,000, right? But of course, we want to know the difference between the mortality rate in the unvaccinated against the vaccinated. Okay, so first of all, we need to know how many of those who die of the virus were vaccinated and how many were unvaccinated. Well, let's suppose that we know that 20 of those who died were unvaccinated, and 80 are vaccinated, right? That means 80 are vaccinated, right? Can we from this work out the efficacy, the relative? No, because in order to compare the mortality rate of the unvaccinated against the vaccinated, we've also got to know what proportion of the population of a whole is unvaccinated. Well, let's suppose we know the proportion is 10%, that there's 10% who are unvaccinated, so 90% are vaccinated. So click through. So there we've got, that would mean that you've got 1,000 unvaccinated, of whom 20 die. So 20 out of 1,000 unvaccinated die of the virus. And that means that 9,000 are vaccinated, of whom 80 die. So if 20 out of 1,000 unvaccinated die of the virus, we know their mortality rate, if you can click through, their mortality rate is therefore 200 per 10k. Whereas only 80 out of 9,000 vaccinated die of the virus, and that's a much lower mortality rate. That's 89 per 10k. So the mortality rate of the unvaccinated in this example is more than twice that of the vaccinated, and that would be really, really strong evidence in favour of the vaccine. That would be very powerful evidence in favour of the vaccine. But what if we got that proportion, that estimate of the number unvaccinated wrong? Let's suppose instead of 10%, the true number was 30%. Let's just run through that and see how that makes a difference. So in this case, you're going to have 3,000 unvaccinated and 7,000 vaccinated. That means 20 out of 3,000 unvaccinated die of the virus. And that means their mortality rate is, just click through, 20 over 3,000. Yeah, their mortality rate is then 67 per 10k, whereas 80 out of the 7,000 vaccinated die of the virus, and that's a higher mortality. That's now 114 per 10k. So in this case, the mortality rate of the vaccinated is almost twice that of the unvaccinated, and that would be very powerful evidence against the vaccine. So just changing that, getting that proportion right, and why? And why is this so important? Because actually, we know that in the UK, in fact, we now know also in the US, studies, which of course, especially these empirical observational studies, which rely heavily on getting a good estimate of the proportion who have been unvaccinated, we know that the estimates massively differ from different sources. So, for example, in May of this year, the Office for National Statistics reported that there was only 8% of adults were unvaccinated. But the UK Health Security Agency were saying at that time around about 20% of adults were still unvaccinated. And an ICM poll that was conducted which was actually used in the BBC documentary called Unvaccinated, and that was a very, very large and very representative poll of UK adults, that found 26% were unvaccinated. So you've got this difference. Is it 8%? Is it 26%? Well, like that theoretical example I just showed you shows you how much of a difference it makes in getting that proportion right. Everything can change. And that's why, I'm very skeptical of studies which haven't got very accurate, assessments of what these underlying proportions are. People talk about getting the correct denominators. That's what they mean when you hear people talk about that.
And these percentages actually transpose through into potentially tens of thousands of lives.
Yes, absolutely.
Yeah, that's incredible. Yeah. Have we got any more slides to look at, Norman? Was that the last one we wanted to?
No, I think that covers everything.
Yeah. So
I was hoping to.
No, that's great. And what I find a bit confusing as well is the Office for National Statistics don't seem to. They seem to be falling into some of these basic errors that you've been describing.
The problem with the Office for National Statistics is that they rely on data given to them from various other sources within the NHS, within the National Immunisation System, and also from GPs. There are lots of points in that process at which errors can be introduced. Right. So the ONS, for example, although it is always the case that if you're looking at just COVID infections and the efficacy of the vaccines, they're using this 2-week rule, and therefore you get that classification of people who got the vaccine who get infected and they're considered to be unvaccinated. With deaths, the ONS are adamant that if somebody does die, even if it's in a day, whatever, it doesn't have to, they don't wait the 2 weeks. If someone dies after a vaccine, they are classified as a vaccinated death. That's what the ONS tell us. But the problem is they're not the ones who are the source of that information. They're getting it from other sources, and the sources they're getting them from don't necessarily record. If someone dies shortly after getting a vaccination, right, or the next day, the last thing they're worried about, this is a real person who's died. The last thing they're going to be worried about is recording, oh, did this person get vaccinated recently? That's not, that's the sort of thing that gets missing. And we actually know, because we looked at the data in detail, and we actually know by simply from analysing the weekly plots of the ONS data on mortality, that we know that there was a misclassification. We know that people, the only explanation for certain peaks that we were seeing in the unvaccinated, shortly after the vaccine rollouts peaked, we know that those peaks can only be explained by people who recently got the vaccine within 2 weeks being classified as unvaccinated who died, right? Because they're dying of we've got this peak in non-COVID deaths of people shortly after the vax rollout, right? And so that can only really be explained by this misclassification. So, we know that happens. The other problem is the ONS, their vaccine surveillance reports rely on a very, very special and really biased subset of the England population, right? It's not the whole population. It's 39 million people, right? Not the 55 million population of England. Namely, that to be in their data set, you had to have been around at the time of the 2011 census. That's why it's only people over at least 10 or 11. And you also have to have been registered with a GP in England in 2019. So you've got to satisfy those both criteria. So 39 million people satisfy that criteria, but it means we know that at least 8 million adults are missing. And those 8 million who are missing are not at all representative of the population who are in there, because these are likely to be, again, a younger profile, people, who, let's say, are less, don't want to, let's say, they don't believe in, they don't feel the need to register with a GP. They might be, healthy. There's a lot of immigrants in there, new immigrants are all in there, etc. And of course, that massively biases the numbers. So in theory, it really could be the case that there are only 8% of the adults in the ONS data who are unvaccinated, whereas in the whole of the population, it could be as high as 26%. And that's, I think, when we did the last video together, that was something that I investigated. So that would mean a massive proportion of those who are not in the ONS database would have to be unvaccinated.
And again, it seems like a fairly basic sample selection error, and for the ONS to take one measure of one statistic for efficacy and a different statistic for deaths seems a bit surprising, really.
Yeah. I mean, we're not particularly happy with, in fact, we were, we actually called for the withdrawal of anybody who'd made sort of definitive conclusions about vaccine safety and efficacy on the basis of those those ONS vaccine mortality surveillance reports. We called for those to be withdrawn because we believe the data was so unreliable.
And of course, you and I are paying
so confounded.
This is taxpayer funded, isn't it? We would expect it to be.
It is, yeah.
To be pretty accurate.
I mean, to be fair, that the people have been, they've always been, good at answering our questions. They provided some, within limits. They provided some additional information that we'd asked for. Some additional sort of more fine-grained data. But we've never got access to the full source data to really get into all of these issues. To be able to resolve them.
I mean, to me, this just shows the massive importance of people like you peer reviewing government groups, and it disappoints me that you don't have access to the full source data that they have. So the independent academics and statisticians such as yourself can run the same tests.
Claim that it's they claim that, of course, they can't release it because they claim that if you're giving finely grained mortality data, then that can easily be de-anonymized, and therefore you would find out, that could be located, that could be isolated to particular individuals, and nobody wants that to happen. But that's the reason why they're not able to do it.
No, but you work within an ethical framework. You're aware of that risk, and you wouldn't do it.
Yeah, yes, of course, we wouldn't do it. We would just make the conclusions, but that's why they won't. That's why they wouldn't be able to release that data.
Yeah.
Well, that's why they say they can't release the data.
Indeed. Well, Norman, thank you so much for that. My mind's still reeling of the fact that placebos can have such high efficacy. It's just such a ludicrous concept. People say lies die in lies and statistics, but it's not. What we need is not disuse of statistics. It is correct use of statistics. And
yes,
people like me depend on people like you to do that. So
and it does, look, the thing is, I mean, we started the conversation talking about sort of Bayesian probability, which people, don't expect people to understand. That's a bit sophisticated. You don't require any sophisticated statistics like that or probability analysis like that for this type of analysis. You really don't. It really is, it's not even a level of statistics 101. It's just simple common sense maths. Simple. That's it.
And again, two main lessons. People like you need access to core data from drug trials, for example, to run an independent peer review and analysis of that. And we need full reporting in not simplistic, but simplified terms in every medical publication. I mean, I'm just talking about the field of medicine here. I mean, in every field, really, but it's certainly in talking about drugs and vaccines and all those sort of things, we need this relative risk, we need the absolute risk, and we need the numbers needed to treat. And for the results, for the side effects, we need the relative risk and the absolute risk. It's not too much to ask, and yet we don't get it. We don't get our extra bowl of porridge that we would like.
We don't. Yeah.
Norman, thank you for all your work and for this PowerPoint. I know this is not.
Can I just make one little
Please
plug?
do.
Me and my colleague Martin Neal we started a Substack which is called Where Are the Numbers?
Yeah. Oh, fantastic.
Substack,
Love Substacks.
Oh.
If you can send us the link to that, we'll put that on. We'll also be posting links to Norman's YouTube channel and to this very same video on Norman's channel, so we can hopefully cross-fertilise between our channels, because I need all the statistical help I can get, and Norman's provided that. So thank you very much, Norman, and great to talk to you as always.
Excellent. Okay, thanks a lot, John.
Thank you.